Hello, everybody. Welcome again. Today, we have amongst us a very distinguished personality from the field of oral and maxillofacial surgery, Dr. Satish Kumar. Dr. Satish is the Professor and HOD of the Department of Oral and Maxillofacial Surgery in Dr. Ambedkar College in Bangalore. He's a gold medalist with international fellowships from the UK, USA, and Europe. He has presented more than 35 papers and delivered more than 150 keynote addresses worldwide. His expertise ranges from implants, oral cancer, and complex surgeries to do with the head and neck region. He's a leading voice in the modern oral surgical world. So, welcome, Dr. Satish.
Thank you, Amal, for such a kind introduction.
It's always a pleasure to have you amongst us, Dr. Satish. So, our topic is nothing very complicated today. We are going to do a very simple topic, which is everything that people need to know about wisdom teeth. So, are you ready to take the questions?
Yes, please. Thank you.
Okay, let's start with the first question, which we normally get to hear from a lot of our patients in our everyday clinical practice. What are wisdom teeth and when do they erupt in our mouth?
So, the wisdom teeth is a term that we call for the last erupting molar teeth in our mouth. The molar teeth are the grinders. And they are called wisdom teeth because they erupt far later than the last molar that comes into the jaw, which is the second molar. And most wisdom teeth come between the ages of 18 to 24, which is, sometimes people think that is when the maturity comes to an individual, and which is why they are called wisdom teeth.
That's why the name wisdom teeth, right?
Wisdom teeth. And it's easier for us to, to keep the term wisdom teeth rather than to, mention it as third molar or the number wise to the patients and to the public. So wisdom teeth is a simpler term to use.
Yeah, it's a much more layman terminology, which the common man can probably relate to. That's why,
absolutely.
Yeah, got your point. All right. Our next question, when should wisdom teeth be removed? What are the indications when you identify, okay, this guy needs to go out of your mouth. It's going to be a nuisance maker in the future.
So wisdom teeth can be removed when they don't cause a problem, which is elective, or when you suspect that they are going to cause a problem in the future, which is again elective, or when they have already been involved in causing a problem, which is either an infection or a tumor or a cyst, which are all pathologies and which are relatively uncommon compared to infections. The most common removal of the wisdom tooth is because of pain in the wisdom tooth. It's either because of decay or because of gum problems when the gums overlying the tooth are infected because of the bad position of the tooth.
Right.
These are the common things, common scenarios where they are removed.
Right. All right. How complicated an extraction it is, a wisdom tooth extraction, as compared to the extraction of any other tooth from your mouth? How different it is?
So it is very different. It is very different because most of the other teeth in the mouth don't go for what we call in the profession as open extractions, which basically means we don't have to drill the gums or the bone to remove the wisdom teeth. But again, most wisdom teeth are in such unfavorable positions in the bone that we cannot use common methods of removal, and then we go for surgical removal of the wisdom teeth. And I personally feel, after having operated for more than 30 years now, we all finished together in 99, 2000. It's been 25 years now, 25 years odd. And I always feel wisdom teeth will give you trouble. So, they're not very easy to get rid of, and they're not very easy to remove, and the best of surgeons can get into trouble when we go to remove wisdom teeth. So sometimes it's as complicated as any of the major surgical procedures that we can do.
Right. A lot, I think, depends upon the level of impaction that they are in. I mean, if something is vertically impacted or totally horizontally lying over there, under the inside the bone, inside the mandible particularly. So getting them out is definitely going to be a much more challenging affair. What do you say?
It all depends on what are the vital structures at any other tooth. You could have a
Exactly. Right.
vertical impaction in association with the nerve, or you've been so many times we've seen the nerve that runs through the tooth, the nerve that grooves the roots of the teeth, and
Right.
many times in a horizontal impaction or any other presentation, the nerves are far away. It's only the tooth that is lying, in a sleeping position. So it's
Right.
all relative to the patient, and many times it can be complicated by systemic factors and other patient factors also. So my
Right.
thing would, there are enough classifications in the textbooks regarding the difficulty of removal of the wisdom teeth. But my take on this is, be prepared for the worst, and try to keep all precautions in mind before you go. Especially if it's possible, I request all my trainees all the time to use magnification when they are removing wisdom teeth. It's always
Right.
better to use magnification, and it makes it easier to remove. Most times, everybody forgets about the tooth that is in front of the wisdom tooth. We all focus on the
Right.
nerve, focus on
Exactly.
the blood vessel, and we don't focus on the tooth that is adjacent to the wisdom tooth. And sometimes irreparable damage happens to the tooth in front. So always, all surgeries, whether minor or major, should be approached with caution, and the need for surgery should be examined completely before putting the knife onto the patient.
So, what
That's
are
all.
the kind of yes, thank you. So, what are the kind of complications do you foresee during the procedure and post-operatively as well?
So that's a good question. It all depends on how prepared you are to do the wisdom tooth removal. And over a period of time, I have seen people where the X-rays have looked very, 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 very simple to remove. These wisdom tooth have come back with jaw fractures. These people have come back with
Right.
tooth that couldn't be removed, and they've been referred to our practice for us to get rid of them. And if you look at the X-rays, you look at the scans, they look relatively simple. I think it all depends on planning. It all depends on going in with an open mind. You shouldn't go in saying that all teeth are easy. You should always go in prepared. And the planning is very, very important, and not deviating from the plan of removing the wisdom teeth is very important. There are other
Right.
factors also that come into play, not only the doctor factors, which is the first thing I'm talking about. We talk about patient factors and environmental factors also.
Right. Right. Right.
So we already spoke about magnification. Visibility is also very important, and it's very, very vital not to compromise on these things. And you should also think about the patient. Young women always think of contraceptives. Older people always think of blood thinners, and nowadays a lot of people are on bisphosphonates. Think of bisphosphonates.
Right.
A very thorough examination and a history of the patient is important before you go on and again try to take the tooth out. Removing the tooth is not at all difficult. Any tooth where you plan, and relatively if you time it in our unit, when we time our residents, and relatively it takes about 10 to 15 minutes to remove any wisdom tooth if you plan properly. But the
Right.
complications happen when you're not prepared for other external factors or intrinsic factors like patient factors, and you don't, you try to do things in a hurry, and you try to compromise on visibility and magnification, and that's where things go wrong. So,
Right.
and you also have to worry about whether the patient is resistant to local anesthesia, and this could be a problem because sometimes wisdom teeth have hot pulps. And when they have hot pulps, how much ever local anesthesia you try to pump into the patient doesn't work. So you have to think about alternative pathways to achieve a painless removal of the tooth. So
And
many
do you
things.
recommend? Yeah. So, do you recommend doing this procedure under local anesthesia or in the OT, in the
Yes,
in
yes,
the under
yes,
general?
yes. See, the thing is taking a patient under general anesthesia, and if you look at the Royal College statistics, we don't have anything from India. But if you look at the Royal College statistics, and if you look at the consent form for the wisdom tooth removal, which is given on the Royal College website or on the ADA website, they talk about 1 in 5,000 deaths, which are totally unexplained in general anesthesia, which means every 5,000 patients that go into general anesthesia, one person can die. And that is very, very important to understand and to get consent for. And local for a wisdom tooth is far more easier because it becomes a daycare procedure.
Right.
The patient comes into your clinic, gets it done, and then you say thanks, bye-bye, and wave the patient goodbye. But having said that, you should not forget about the ease and the comfort that the general anesthetic background gives you as a surgeon. The only thing I would think of is taking all things into consideration and forgetting about the risk factors. The most difficult thing to do in general surgery is to keep the mouth open. I mean, general anesthesia is to keep the mouth open.
Right.
My apologies.
Right.
So
Right.
keeping the mouth electively open is extremely, extremely difficult under general anesthesia, and that sometimes gives you trouble.
Can
But
backfire. Yeah.
if I feel that there are vital structures nearby, I don't want the patient to jump, scream when I go near the nerve, or if I think there's an artery that is there which I see on the scan, which I think is going to be a bleeder under local anesthesia, or if I'm going to do 4 wisdom teeth at the same time, which are deeply impacted and which are not favorable, which I feel that there will be some amount of this discomfort for the patient, whether I inject local or I do it under sedation, then I have no problem at all in doing this under general anesthesia.
Right. And how simple or complicated is the post-operative healing before a person gets back to the normal routine of eating and
So it's not. So this is out of the hands of the doctor, really, most
Right.
times. So there are doctor factors and patient factors. No, 90% of the time, not really doctor factors, because everybody is going to put a suture in, everybody is going to put the tooth out, and everybody is going to send the patient home with hemostasis, which basically means you send the patient home after the bleeding stopped. It's the patient factors that come into play here. A lot of people create negative pressure inside the mouth. They hawk and they spit, and then the clot breaks. And I've noticed that once the primary clot breaks, many times the secondary clot doesn't settle down.
Exactly.
And I know colleagues of mine that pack the socket with either graft or with gel foam, but there are enough studies to show that this is not really good clinical practice, because these themselves can cause problems later on, whether it's an infection or there is a paresthesia or temporary numbness of the nerve. So it might be a good idea not to do anything that your doctor tells you not to do. And another big problem in India is tobacco abuse. So
Yes.
I've known people who you get rid of the wisdom teeth and then you go down to have a cup of tea, and he's there saying, "Hi doc, why don't you join me for a cup of tea," with a cigarette in his hand.
Yes.
So these are things that cannot be got rid of, really. So
Yes.
each surgeon has his own protocol on what to do. And if I have a person who's a smoker, then I would probably pack the socket with Abgel or PRF and put in some nice permanent sutures instead of going with resorbable sutures, because I always feel that the rate of infection, this is just my observation, there
is
no
much
evidence.
more. Yes.
Yeah, there's no
So
evidence.
basically, patient compliance plays a pretty large role
So we
in
all
the
have our own
post-operative
ways of
healing.
trying to make sure that it works for you, because when a complication happens, it's very distressing for the patient as well as for the doctor. So it goes both ways. It's not only for the patient, it's for the doctor also. Nobody wants to see a clean surgery go wrong,
Yeah.
So
can we talk a little bit about dry socket? What exactly is a dry socket?
There are a lot of hypotheses, and when we were training, we were told and we were taught in surgery that dry socket was because of loss of clot. But then the Israeli surgeon Nitzen has clearly proven that it's a bacterial infection, and the bacteria is one of the common bacteria that is found in everybody, which means it's basically a harmless bacteria till you do something that aggravates it. And this is a spirochete which causes this particular issue by infecting the clot. But having said all that, the patient is not bothered about why it happens. He only is bothered about the pain, and he's only bothered about how quickly he can get rid of the pain, because it's excruciating. It's a very dry patch and foul-smelling socket inside the mouth, and there are many ways of treating it. Let's not get into that because this is not the forum for that. But it is basically a socket that's lost its clot. How it's lost its clot, what you think of, what are the hypotheses, how you want to treat it is a totally different thing, and I don't think it belongs to this particular platform.
And most often than not, when it happens, the doctor is blamed for.
It's very difficult to treat. It's very difficult. Which is why, off late, I've noticed that with the advent of common use of oral contraceptives, it's become quite common in young women who don't smoke.
Okay.
Because there is enough evidence-based literature that says there is, oral contraceptives cause the cord to break up. So that is something you have to figure out, and you have to keep in mind before you go in, because many times if you do a normal wisdom tooth delivery, you don't really put sutures.
Right,
I prefer
exactly.
not to put sutures unless necessary. The sutures themselves can cause infections.
Yes.
So you keep the socket open and allow it to heal on its own. But that's where the history comes into play, really, and consent.
All right. I think we'll end the session for today over here. I think we have addressed most of the common questions that we get to encounter in our practice. Let's come back again with a different topic. Probably we can talk a little bit about oral cancer next time. We can decide on the topic. Thank you very much for your valuable time. Thank you
Thanks,
once again.
Dr. Amal, and thank you to your team. As always, it's been a pleasure. Cheers.
Pleasure. Pleasure having you, Doctor.